Okay. Hello, everyone. Welcome back to the Reconnect Health podcast. Today, we are very fortunate to be blessed with Regan Haley here, who is a physiotherapist. But Regan is not only a pelvic floor physiotherapist, she is also a pediatric physiotherapist. And today, we're going to focus on peds because I think a lot of people don't really understand what's happening with pediatric physiotherapy. They might not know that there's pelvic floor physio that is being done in the pediatric population. So, why don't you talk a little bit about how you fell into this and what you're currently seeing in your practice from a pediatric perspective?
Okay. Um, well, I always knew that I wanted to work with kids like ever since I was young. I didn't know what that would look like. Um, but my mom's a physio and we had kind of talked it through when I was in university. And then I decided that I wanted to do peds physio. Um, so, went through physio school and then some extra courses and stuff to do the pediatric training. Um,
Which is
and
like a big
then
jump because you don't get a whole lot of it in university. Like you have to
yeah,
go out and seek additional training. It's
yeah.
similar to pelvic floor in that you have to go out and kind of carve your own education path.
Yes, exactly. I found like in school we had one course on it and it was obviously very broad, very general, um, kind of like the basics that you would need to know if you saw a pediatric patient, as opposed to like being a pediatric physio. Like I
Right.
think it was like, this is what you should know about peds. And then you could send them to whoever you feel they need to go to.
Right.
Um, and then I was very fortunate to work with when I was working at the Moncton Hospital, I worked with, Denise and Derek, 2 amazing pediatric physios there, so they were kind of my mentors, in all of this. And then, yeah, some extra courses, but and mostly what I do is orthopedic pediatrics, so, like, musculoskeletal as opposed to, a lot of the time we talk about pediatric physio in, like, a neurological sense, so like babies born with CP or Down syndrome, which I don't have as much training in that area. So I wouldn't really say that that's my area of expertise. But so yeah, with orthopedics, we see a lot of torticollis.
Right. So what's torticollis?
Torticollis is when a baby either is born with or develops like tension in the neck. So often they're like kinked to one side, or they can only really look one way and don't like to look the other way. I find it's almost a little hard to see it as a parent when they're really, really little because they don't really do much anyway. They're not moving that much. But once they start to move like 2, 3, 4 months, you can start to see like, okay, yeah, they're really only looking to one side. Often that can lead to like flat head on one side. If they're only looking one way and resting one way long periods of time, that can flatten the back of the skull. We've been seeing a lot of lip tongue ties as well, which kind of goes hand in hand with both of those things, the flathead and torticollis. If ever Whenever I see a baby with either flathead torticollis, I always check for lip tongue tie. Um, they usually kind of work together.
That's interesting. What do you think that is? Like, what's that relationship?
Well, the lip tongue ties is really like a piece of tissue in your mouth that's not stretching as well as it should, or not placed in the mouth maybe as best as it could be, which makes the muscles around the mouth, the jaw, the lips very tight, which then kind of travels down into the neck. So if it's tight one way or the other or in a certain position, usually the baby develops like a preference to feed on one side. So then the muscles get really strong on one side. And then that can impact, going downwards. If they always want to feed on one side, they're always going to be looking in the same direction.
So the asymmetry kind of continues down.
Continues. Yeah.
Interesting.
Hmm.
Okay. Are there things that parents should be looking for to kind of check for these things? Because you were saying it's sometimes difficult for parents to see the head turning preference.
Yeah.
What would you counsel to parents to be looking for?
In terms of torticollis, I would say like noticing if when you put them down, they always put their head on the same side, like they'll always look to the left. Or like when you go in and you go to get them from their nap or whatever in the morning and they're always looking in the same direction all the time. That would be one hint. In the car seat, if you notice that they're like, oh yeah, they always like flop to one side or look to one side. that, and then with lip tongue ties, and if you notice, like, okay, one side of their head is getting a bit flat or the back seems flat, straight across. Lip tongue tie is mostly like issues with feeding. So if you notice that difficulty with latching, like if breastfeeding feels like a challenge or bottle feeding, they're having a difficult time latching. Or it's really painful on the mom, that can be a sign that there's something going on. A lot of like sometimes it's like they'll feed like really short and then they have to come off and then they'll go back on and feed for a little bit and then come off, like almost like fatigue, like they can't feed long periods of time because they get tired. Another thing is like it almost sounds like clucking, like some
Oh,
sort of
yeah.
like noise. Yeah, when they're
Like the
feeding.
seal being broken. Yeah.
Yes, yeah. Or like a lot of milk like coming around the outsides of the mouth during feeds. Yeah, those would be lip tongue tie kind of indications.
Right.
Mhm. Or reflux is a big one
Mhm.
too. We see a lot of reflux and um yeah.
So what does treatment look like when you're talking about treating those kind of three common conditions that you see?
Yeah, a lot of the time, I mean, I'm very fortunate here as well to have Dr. Adele, our chiropractor, and we will often, if we feel it's appropriate, we'll work together on a case or at least discuss certain cases together, which has been really helpful. She's kind of guided my knowledge and treatment on lip tongue ties. But it could be anything from like release of the neck muscles, so myofascial release, stretches that we give to the parents. Sometimes like facial massage. So Alicia, our pediatric massage therapist, we've been working together as well on these cases. Sometimes I do find it takes multiple people. Um, we all have different areas of expertise, and sometimes I feel like, oh, Alicia might be able to target that better than I could, or something along those lines, or have 1 half-hour session to just do the massaging part, and then in physio we can work on the milestones or some other body work techniques. But often what happens with the lip tongue tie or torticollis or flathead, usually their milestones start to fall a little bit behind.
And you mean like motor milestones,
Yeah.
like
Yes, motor
sitting,
milestones, yeah.
crawling, that sort of thing.
Yeah,
Okay.
rolling, you can imagine if, like, your neck was always tight on one side, you wouldn't feel like you can do certain things on that side, um, either due to discomfort or just, like, physical can't do it
Right.
because of the restriction. So, yeah, it's a lot of, like, an in-depth assessment, and then kind of I always like to target, like, okay, what are the big problem areas? Like, what's not happening or what is happening that's causing certain things to not happen. Um, so yeah, it could be facial massage, could be working on milestones. Usually there's stretches involved and homework to send home with the parents, a lot of education. Like especially for torticollis, ways that we can get them to look the other way that might not feel that intuitive at home when you're just, especially when you're, in that early postpartum, kind of in survival mode. But yeah, so a lot of education as well, certain positioning techniques that you can try. And then if we feel like I always love to try conservative management first, like physio chiro massage. And if we feel like, okay, it's not improving or it is improving, but not maybe as much as we'd like. Or I always say, like, if a baby is really not thriving, like, babies will find a way to survive. They that's what we're here to do, and if they feel like they can't feed on one side, they'll feed on the other. They'll learn how to get through it, and they're not thinking like, "Oh, my neck hurts. I'm gonna feed on the other side." They're just thinking like, I need this food." So, if we feel like, okay, it's really not improving and often they develop all these compensations, like ways that they've managed to feed, um, we can always refer to someone that will, like, do the procedure for the lip tongue tie.
Right. Which we're
So,
starting to see a little bit better access to and better ability to determine who's a good candidate for that now, I
yeah,
think. Yeah.
yeah,
Which is nice.
yeah,
It's interesting that you talk about all the collaborative care that's happening for this,
mhm,
which is, I think, ideal, right? I think that
yeah,
every kind of profession has different tricks and tools and different education. And so it's nice to see that there's like a pediatric team that that are working with these patients.
Yeah, definitely.
Yeah. Another thing that I wanted to talk to you about is actually pediatric pelvic floor.
Mhm.
So I know that you see this world of babies and you do see a lot of the head, neck, and mouth issues. But we are also a pelvic floor clinic. And so we end up seeing a lot of these pelvic floor patients.
Yeah.
And what, like the common things that we see coming, I think, are like giggle incontinence. So that's leaking when the kids are laughing, or we'll see bedwetting that's going on. There's basically an epidemic of like chronic constipation, I think, in
Yes.
children that we're seeing a lot of.
Yeah.
And I'm seeing more and more of ADD or ADHD focused toileting
Mhm.
behaviors as well, like kids who are busy playing and don't
Don't wanna
feel
go.
the
Yeah.
signals to go. Yeah. So is that what you're seeing in your practice as well?
Yeah, I would say it's very, very similar. The chronic I would say most of the time, the things that I'm seeing in the end, there's constipation. Like
Right.
it all comes down to like, oh, there's constipation or
Okay,
like
explain that.
most of the things that I would treat like bedwetting, not always, of course, there's always gonna be cases that aren't this, but um bedwetting, even like when I'll ask them like, "Oh, did your child when they were a baby, did they crawl?" No, they never crawled, they bum scooted or
Right.
something. So like, okay, we know that like crawling is very, very important for many things, but one of them being core control, and lack of core control can sometimes lead to constipation without as much like
Abdominal pressure to push is what
yeah,
you're
to
referring to, or
push,
like
yeah.
sitting on the toilet. Yeah. Okay.
And even just like I think like, if you think about how the large intestine works, if there's more, resistant support on that area, it's going to work better than if, it can go slower if there's not enough,
Right.
resistance there. Um
And so the bowel sits right behind the bladder. And what we'll see is if you've got a full bowel, it can actually press onto the bladder from behind, leading to leaks. So
yeah,
parents will feel that the urinary leakage is the problem and they present to our office.
right.
But then we're like, how often is your kiddo pooping? And like by school age, parents are checking.
Yeah, exactly.
And
That's
it's
what I find the
like,
most. Yeah, like they're like, "Oh, I guess I think every day." And then the kid's like, I'm not
no, like
sure
twice a
yet."
week.
Yeah, yeah.
Like what? So
Yeah.
there's like a lot of information that comes out in those initial like
Yeah.
discussions I find.
And usually parents will say like, "Oh, like I didn't think to ask that question." Like
Yeah.
that's what I find. I find pediatric pelvic floor especially is so much education
Yes.
with the parent and the child, and usually it's nothing like, mind-blowing. It's just you probably didn't think to ask that
Yeah.
question.
We're not having kids do like a bajillion Kegel
Yeah,
exercises. That's
no.
what's happening.
No. Yeah.
So some like basic techniques like in that education, like it's just like, have you actually started like talking about taking time to have bowel movements? Do
Mhm.
they have a bowel schedule? Like, do they go poop at the same time every day? I find the biggest problem is that kids in the morning, and like I'm a mom and I feel the same way, like we're rushing to get out the door in the morning. So if a kid gets a bowel urge in the morning, it's like, well, sorry, the bus comes at 7:30. Like we
Yeah.
don't have time, right? And then after school, they're either going to like after school care. Well, kids do not want to poop at school. A lot of adults
Yeah.
don't want to poop at work. Like a
Yeah.
lot of kids just will not poop at school. And then they go to after school care, or they're like, we're rushing off to 8 bajillion, like piano lessons and
Yeah.
math tutoring and hockey practice and like all of those things. And then you get home and you eat dinner and it's homework time. And then it's like, they might not have even had time to poop all
Yeah.
day, right? And then it's like you have to wait for the next poop opportunity to arrive.
Yes. That's a great word. I am always shocked when I'm going because I always ask the child, like, "Can you lay out your daily routine for me? Like, what do you do?" And I'm always shocked at how busy the kids are. Like, I'm
Yeah.
like, "Oh my god, you're busier than I am. You just go, go, go all day."
Yeah.
So by the time things feel rushed in our society in general, especially toileting, and I feel like that's kind of for everybody. Like
Yeah.
a lot of patients I see, like peds or adults, sometimes I'll just say like, just sit there, like use that moment if you can. 2 extra minutes on the toilet might make a big difference, but um, yeah, there's a lot of rushing and so yeah, that can lead to
Like just developing a bowel
constipation as well.
schedule.
Yeah,
Yeah. And then, do you recommend any kind of equipment for the toilet? Because I know I talk to my patients about that sometimes.
yeah, I always recommend the toilet posture. So feet up on a step stool, or like I have some kids that are really flexible. They'll just like put their feet right up
On
the
the
toilet
seat.
seat. Yeah, and sit like that. But any position that they can get in where their knees are higher than their hips, and then they can kind of like lean forward and rest like that so that we're kind of like mimicking a squat position.
I think people forget, like, if you were sitting on a really tall bar stool and your feet were dangling
Dangling.
and you had to poop in that position, like, it's very hard to generate,
Any
like,
amount of
yeah, you
force. Yeah.
really want, like, good foot contact. So them on their little tippy toes is not gonna be enough.
Yeah.
And then the other thing I see is some of them are so tiny.
Yeah.
If your child is holding on to the toilet seat to
Yeah.
stay there, like, they need a potty inset, like
Hmm.
something into the toilet or like one of the potties that go on the floor. But like
Yeah.
a lot of them wanna be like their big siblings or like mom and dad and don't wanna use those things, but then
Yeah.
they're like it's a core workout for them to just
To
hang
hold
out.
themselves, just to literally sit on the toilet.
Yeah.
Yes. And then you can't focus, I find. Like you're trying to hold yourself there. So you're not your brain power can't go to what it's there to do. And also a thing that I see is like screens in the
Yeah,
bathroom, like playing on the tablet, which is going to, again,
the distraction.
it's so distracting for them. And it sounds funny. We would think like peeing and having a bowel movement should be like, autonomic functions. We shouldn't even have to think about it, but we do really. So yeah, that's always one of the things I say too, like no screens, even if, we need to transition out of that, you could bring a book or, something else, a Rubik's Cube, I don't know, whatever, fidget
Yeah.
spinner.
Something. I know I do find then, like, I'm guilty of that with my kids too. It's like sometimes the screens are used to entice them to go on the toilet.
Mm,
Like if you come sit on the toilet, you can have, 5 minutes of screen time while you're pooping and peeing, right?
yeah.
But then you're right, it gets to be like a slippery slope. It ends up being a difficult habit to break. And then you've
Yeah.
got a kid that's just going and sitting on the toilet to watch their favorite show and
Yeah.
they're there for 25 minutes.
Yeah. Didn't even
Didn't do
have a bowel
anything. Yeah.
movement. Yeah. Yeah.
So it's like this balance
Yeah.
that can be a struggle, I think. Yeah.
And I find the pediatric pelvic floor physiotherapy, a lot of the things that the kids are struggling with are feel very debilitating, and they can really impact the whole family dynamic.
Absolutely.
So that part can be tough too. Like often once the parent arrives, I find they kind of give this sense like we've tried everything, like we don't know what else to do. Our routine's thrown off. They can't have a sleepover. They can't,
They're bringing clothes to school.
yeah,
They can't go to. We get a so in June in the summertime we always focus on this because we know that come August we get like an influx of calls of people trying to do potty training before kindergarten starts or potty training before school starts.
yeah,
And you need to come in before. Like giving us 3 weeks isn't enough time. We usually need a couple of months to work on this.
yeah.
And
And none
so
of it, I would say, is like a quick fix. Like a
no.
lot of it, it's like building routines, building habits. It takes time. It does take energy. So you want to have like a good chunk of time to be able to
Yeah.
work on whatever it is we're working
And
on.
you're right, like, the parents are tired, like, if you're waking up 3 times a
Yeah,
night
the
to
sleep.
change bedding or
Hmm.
because kids are up, like, the sleep issue is really problematic, and
Yeah.
so I really feel for parents because, I find they then will go to sometimes they'll go to medicine and ask for help, like, from their physician, and
Mhm.
the physician is like, "It's normal till they're 9 or 10 or
Yeah. They'll
12,"
grow out of
like
it at 12
and
years
it's
old.
like so then you've got a 12-year-old now that's still wetting
Hmm.
the bed, and it's like, well, how do they go to sleepaway camp
Yeah.
and what happens if the constipation gets so bad that they start having accidents, like fecal accidents, right? And
And
so
if they're six,
Mm.
are are you just like, okay, I guess we'll just do 6 more years of it and hope that once
yeah,
they
like
turn
how do the
12.
parents thrive in that
Yeah.
environment
Yeah.
too, right? So I think it can feel very exhausting and hopeless when there's not a plan in place. And
Hmm.
so do find the first number of appointments are really just like, okay, here's the plan.
Yeah.
And we know, this is like the net for the next 3 months. We're
Yeah.
on board with that happening,
Yeah.
right? Yeah.
And it really is. I find most of the stuff for the Pete's pelvic floor is like a daily routine. None of it takes a super long time. But it is like a bit of a shift in, okay, how are we gonna, work our day around this? How can we fit this into our day to
Yeah.
make it more of like a routine? And I always mention too with pediatric pelvic floor physiotherapy, I don't know about you, but I would rarely do, an internal exam or an exam even without their pants on. Like usually I can do everything that I need to do with them fully clothed.
Yeah.
So I just like to mention that because I can't imagine. I'm not a parent, and I would feel, that would probably be very terrifying, and for the child. And I had this one kid once, and she was maybe like 6, and she was telling me about something that had happened to her when she was 2,
Mhm.
and the mom was like, "I don't I'm shocked, like, I've never brought that up to her, I can't believe she remembers that," like, and it had something to do with, going to see somebody for the constipation, and so it just kind of hit me like, oh, that she really remembered that, and, like, that was, like, embedded in her, and I don't you wouldn't want to put a child in a situation like that if I feel like, okay, we're really not
Yeah, I agree.
something needs to be done, like, we're not getting to the bottom of it, or, there are some internal treatments that can be extremely helpful, and if that's the area that we need to go, we can, but for the most part, I find I can almost do everything with them fully closed.
Yeah, I
Yeah.
think I mean, generally you want to go least invasive first, right? And there's so much that needs to be done, usually from a foundational point.
Mhm.
It rarely gets to the point where we're actually investigating the pelvic floor muscles. Like I said, like it's rare that kids have to do Kegels. It's oftentimes that they're actually too tight, they're gripping to a
Yeah.
toilet, and we have to work on relaxation.
Mhm.
So it's usually like general stretching, and discussing with doctor or pharmacist, maybe or a dietitian about how to manage constipation.
Mhm.
But I think that you're absolutely right. It's rare that it gets to that point. And if it does get to that point, like there's surface electrodes that you can put
Mhm.
around the bum that like I teach the parents how to just move underwear out of the way and put an electrode on, and we can
Yeah.
put things up on a biofeedback unit. And there's education to both the parent and the child if ever like touching needs to happen, right?
Yeah.
But generally it tends to be like hip stretches and abdominal massage and that sort of thing. But I think you're right. I think that it's been so common now, especially like when I was my kids are 8 and 10 right now. And when I was potty training my kids, it was like the 3-day potty training method was
Mhm.
really, really popular. And I get why that makes sense. Like some daycares will charge you more if your child's not potty trained. And there's
Yeah.
just so there are a lot of people who are trying to get this done really, really quickly. And I find that there are some bodies that respond to that very well,
Mhm.
and there are others that just do not respond to that well at all. And so if that's societal norm is that, oh, well, you can potty train your kid in 3 days, then
Yeah.
for those that it takes like 6 months to a year to potty train, you feel very much like you're behind or you're failing as a parent or like,
Yeah.
what's wrong with my kid that they can't do this? And
Mhm.
so I just want to highlight that that's not the norm. Potty training doesn't happen like in 3 days for
Yeah.
the majority of
Yeah.
kids.
So true. Yeah.
Yeah. So is there anything else that you feel like we should cover? We've got a couple minutes left, or do you feel like we've given like that's a good description of what you're seeing day to day?
We could go over a little bit about the milestones, like, that would be another huge part of my practice, the motor milestones, like, from, like, 0 to 1 or 0 to 2 years old. I think that's something that sometimes I find there's a lot of stress around milestones, like, "Oh, they're 6 months old and they're not doing this, this, and this, like, something must be wrong," when really, like, I do truly feel like every baby is different. Every baby is gonna follow their own, trajectory. And when you're, like, looking at a checklist of the milestones, I'm sure that could feel very daunting, and I know that you want your baby to thrive and do well. So, sometimes it's a lot of, like, reassurance that, like, they actually are doing well and there's nothing wrong and, they're progressing in a nice trajectory with their milestones. But sometimes there is, like, I'd say easy, but like exercises that you can do at home that they're not really exercises. Like it's like this is a way that you could play with your child that is going to help them develop their, this specific milestone a little easier. And to the baby, they don't think you're doing exercises.
Yeah.
They just think you're playing. And
It's not physio today.
yeah, yeah, exactly. Usually for the most part, the sessions are fun and the baby's having a good time and the parents having a good time learning some techniques that you can use at home. We talk a lot about, crawling and once the baby starts like moving around, ways that we can really like optimize that. And then obviously if there's something like not obvious, but that's standing out, that's something, okay, maybe there is something going on here, but often it's like, oh, their right hip is a little tight, or like the left side of their neck's a little tight. Like it's things that we can work on together, that will again just like optimize their development and make things easier for them. It's not always like, oh, there's something going on, referral to pediatrician. Like it's not always something sinister like that. Sometimes it's just like another thing that we can help with physiotherapy or chiro or massage. So that part of my practice is really fun too, and helping parents feel like, okay, now I just have a list of like 5 things that I can do that
Like play, like
just switches up our playtime a little bit. And
Regan is highly skilled at like making all of the physio really feel very play based and like so it just naturally goes into how you're playing with your baby anyways. It's just play with them on the left side instead of the
yeah,
right. Like
yeah,
little things like that, which can be really empowering to the parents. And then they see the
yeah,
improvements too,
yeah,
right? Yeah.
yeah. That part is really, yeah. They come back the next week and they're like, within 2 days they were doing it, and I'm like, awesome, I love that. Sometimes it's really easy. It's just not stuff that you would think to do. Like, it's not a milestone, but I always call them like mini milestones. Like, it's kind of like the prerequisite in order to do the milestone. So I'm just giving you those little prerequisites that they need, that little boost to help them do whatever the milestone is.
Well, that's
Yeah.
really great. Thank you
Yeah,
so
it's
much
fun.
for
Thank
sharing all
you.
this information.
It's fun.
I'm sure people will have questions. You have questions, please reach out. We can
Yeah.
always do another session like this.
Yeah.
But thank you so much for your time. If you're looking for Regan, she's at Reconnect Health.
Yes.
You can book an appointment with her
Yeah.
for pediatrics, for assessments. And please don't be shy. Send out some messages if you've got any questions at all. Right?
Thank you.
Bye.